welcome to the fourth episode of season 1 of Race in Society, where we're focusing on the theme of race and COVID-19. My name is Alana Lenton, and my co-host Zulika Zubalos is behind the scenes this week. We broadcast on our YouTube channel every 2 weeks. Please remember to subscribe to our channel to get all the updates of our upcoming sessions. This week, we're looking at the theme of the lockdown, healthcare, and racist ableism. Before we begin, I acknowledge that I live and work on the lands of the Gadigal people of the Eora Nation. Aboriginal and Torres Strait Islander people have been exposed to new diseases, denied adequate healthcare access since the time of invasion, and continue to face intergenerational trauma, both physical and mental, that is caused by racism and ongoing colonization. We acknowledge Aboriginal and Torres Strait Islander people's resistance and their ongoing autonomous care work, and Aboriginal controlled health organizations' ongoing contribution to social change. Aboriginal people's conception of healthcare has always been holistic, enacted through self-determination and racial justice and connection to country. Disability studies have long been dominated by white, non-Indigenous frameworks which ignore race. The work of Professor John Gilroy and other Aboriginal scholars show that the field of disability regularly assumes that white, middle-class ways of understanding disability are universal, and they therefore enforce whiteness upon disabled bodies. Our panel today will unpack the ways in which Aboriginal and Torres Strait Islander people living with disabilities can be better supported in the health system, how to establish cultural safety during the pandemic, and what an anti-racist response to healthcare might look like. So first, I'd like to turn to June Riemer. You, June, are the Deputy CEO of the First Peoples Disability Network. Almost half of Aboriginal and Torres Strait Islander people living with disability or have a long-term health condition. The Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability is ongoing, as we know. So we want to know, would you be able to talk to us about the Commission's concerns about reduced oversight in closed residential settings particularly, and maybe other race-related concerns that have been raised about the impact of COVID-19 on Aboriginal people with disability?
Yes, thank you. Thank you, Alana. I too would like to acknowledge all Aboriginal people and on lands that we may be sitting on today, and acknowledge our Aboriginal and Torres Strait Islander people. I'm a Gumbunja Dhungutti woman from the North Coast of New South Wales, and I'm sitting up on beautiful the lands of the Nambucca Heads. So so I'd like just to acknowledge those who are listening in today, and for other non-Aboriginal people that want to hear more and learn more about how to support our communities. So at the beginning of COVID, FPDN as the national peak, we were watching and acknowledging, particularly in America, that that those of colour weren't possibly receiving the same health outcomes or health protection or supports with COVID-19. And, we were really concerned around our group, particularly those living with a disability, being triaged out of healthcare, or those, with chronic health conditions. So it was a real concern for FPDN at the very beginning, and thank God, Australia didn't see the numbers that, other countries did. But we were still concerned, and we're talking about early February, March, April. So we decided to start looking at putting together an ethics paper to give to the health system, because I think it was maybe late April, the health paper came out in regards to supporting people through the health system during COVID-19. And in the 62 pages developed, there really wasn't much around Aboriginal and Torres Strait Islander people. There was actually nothing for people living with a disability. So this made us even more concerned, and those with chronic health conditions, because what we saw in other countries, if you were a Black person with a disability or possibly a chronic health condition, you were triaged out of the health system during the numbers. So we developed an ethical paper with support of the University of New South Wales and presented that to federal and state governments and the healthcare system to ensure that they would look at other ways of supporting, if possible, those living with a disability or those with other chronic diseases. So some of the other work we did during this period, and I mean, I think for us, our 20 years of work being the only national peak representing Aboriginal and Torres Strait Islander people, sadly enough, it came to fruition, all the narratives that we've been saying for a very long time. Our people with disability live in extreme forms of poverty and disadvantage. So COVID for us just, highlighted those, elements of poverty, disadvantage, remoteness, homelessness, overcrowding, lack of utilities, lack of, clean, fresh drinking water, lack of support with, PPEs. These are just all normal everyday occurrences for a lot of our MUB, in particular regions across Australia. So it wasn't nothing new to us. So we were asked to sit on many COVID committees federally, and, we were bringing up these issues that, you can find in Hansard's, as far back in the 1990s, our founding member, Uncle Lester Bostock, was writing about this, about double disadvantage. So COVID-19 for us just, highlighted, the already extenuating situations that our community live in. The positive side, I think that our communities didn't wait for the government to come along and support them. They just rallied themselves together, particularly areas like APY Women's Council, the Wreck Bay down in the Shellhaven region, out at Menindee and Brewarrina, areas like that. They closed off the community themselves. They didn't wait for government. They didn't want any foreigners coming into the community because first and foremost, they want to keep their elders safe. Our elders are the national library of this country. And our government couldn't even recognise that when the APY Women's Council asked for some of the elders there to be removed down to Adelaide, and they were going to pay just about keeping them safe and having them supported in a facility where, they could get any other, health support they may need in this period. So I think that's the resilience that our Aboriginal communities, we've had 200 years to learn resilience and not rely on other people. And I think, the numbers show in itself that, COVID really hasn't hit our Aboriginal Torres Strait Islander communities, because if that's one thing we do well, we look after each other. We don't wait for other people to come along. We bandy together. We are a community. People don't think we're a community, but we're a community. And when things need to be done, we just do it whether we have resources or not. The other thing that was, lucky for FPDN, we were actually approached by an international food foundation, the Alishan Foundation, that actually works in war-torn regions across the world. They approached us and asked how could they help the Aboriginal and Torres Strait Islander community living with disability, and supplied us with emergency food packs. We had to distribute it, but they supplied it. So to today, we've distributed over 2,000 emergency food packs, mostly to regional and remote regions. But we did start in the Shellhaven region of New South Wales because we knew particularly the elders down there were still affected from the recent bushfires. So, again, I think when things need to be done, Aboriginal and Torres Strait Islander people bandy together and just get it done. And those food packs were distributed by volunteers. We had to coordinate it all on the FPDN side of things, and some of our workers work day and night coordinating lists and gathering names and addresses where people, may need support. But the community itself came together and helped us as volunteers delivering those food packs to community. And I think that's, the strengths that our community are, when it needs to be done, we get it done. I think the other part in this conversation, in regards to the Royal Commission, again, myself and our CEO, Damien Griffiths, just gave evidence at the Royal Commission around COVID-19 and the extenuating issues that happened, particularly across a lot of our communities in, you know, overcrowding situations when we're asked people to, you know, self-isolate. There isn't anywhere to self-isolate for a lot of our communities. In regards to, you know, fresh, clean drinking water or hand sanitizer, most of the supermarkets in remote communities emptied very early. And this was an issue that we saw for many communities because particularly those that were on the basic cards, you know, so even when they, you know, had some sort of funding to get to the supermarkets, the mainstream communities, and I'm happy to say it aloud, wiped out the supermarket shelves. They didn't think of others. Where, you know, in our communities, I know we're living up here, every time I'd go to visit an elder to see if they're safe and they need anything, the first thing they'd say to me, do you need something, girl? You know, Dort, what can we help you with? And I go, no, you keep all your stuff. I'm fine. But that's what we do in community. You know, I work and I don't need to be supported, but my community here kept going, are you okay? Anything we can do to help you, you know? So I think there's a lot of lessons to be learned, and you know, in regards to the Royal Commission, we FPDM will, you know, hold strongly our concerns and keep writing our issues papers and submissions in regards to, you know, education outcomes, housing outcomes, health outcomes, you know, institutionalizations. We don't believe in institutions, and you know, mostly a lot of our mob are not in institutions, but you know, COVID-19, as I said, brought out these extenuating issues where everyone talks about, you know, being isolated in this period. I think for Aboriginal and Torres Strait Islander years, we had 200 years to learn to be isolated and put back, you know, back into, you know, the extremities of society. You know, we learned and grew that way. You know, we learned from our elders, we learned from our grandparents that we, you know, couldn't walk mainstream. You know, we always had to be second class, and that goes to that intergenerational racism and trauma, and that's things that Aboriginal and Torres Strait Islander people live with every day. So when COVID-19 came along, I think our mobs, you know, survived this really well, and are still surviving this very well. So I think I'll leave it there. I'm not sure how long it is, but yeah, happy to answer any questions. Thank you.
Thank you so much. I think there's a couple of things emerging there. One, which we've heard really in all the panels from the Aboriginal community-controlled health organizations, is the fact that COVID-19 merely accentuates crises that have existed since the time of invasion. But the other part that you've accentuated really well, and I think, you know, really illuminated for us, is the fact of autonomy, of Aboriginal and Torres Strait Islander autonomy, and intra-aid or inter-aid. And I think what's interesting about that, because we've seen the kind of the growth of mutual aid groups in various neighborhoods around the place due to the COVID-19 crisis. But what I think here is what the general community or the settler community can learn from Aboriginal and Torres Strait Islander communities about how we want to live life in the future outside of the state, or doing our own thing autonomously to care for each other in these times, which are really difficult for everybody. So thank you so much for that.
Thank you.
I'd like to move on to Associate Professor Lalonde Bandler. Thank you so much for joining us. You are a Principal Research Fellow for Leaders in Indigenous Medical Education Network. Now, remote Aboriginal communities have implemented social distancing preemptively, as we've been hearing, to protect their people due to the higher risk of COVID-19 among these communities. Over time, we've seen inequalities in terms of the imposition of restrictions on communities. So in light of that, could you talk to us a little bit about the concept of cultural safety and explain that to us? And how do you think this can be used as a tool for confronting more broadly systemic racism in healthcare, and especially during this time of the lockdown with regards to the pandemic? Thank you.
Well, thank you, Alana, and thank you for having me as part of this panel. And can I just start by acknowledging the traditional owners of the land on which the communities we serve rest. I'm here on Guringai land, and I acknowledge the communities across Australia where Aboriginal and Torres Strait Islander people have ongoing custodianship of land never ceded. So I take this moment to pause to acknowledge and pay respects to elders, and to take heed of their ways. And gatherings across Australia have occurred for many thousands of years as people join together to have conversations about how to live, how to do things better, how to care for people, and we follow in those footsteps. To come to your question, Alana, around particularly cultural safety, and I guess in the first place, I'd like to recognise that that term grew out of work done by Indigenous Maori nurses in New Zealand. And I think it's useful to go back to the origins of the term to understand just how political this term actually is. So, you know, I take this moment too to acknowledge the work particularly of Ramsden and her colleagues through the 1990s and beyond. And the concept of cultural safety arose from the colonial context of New Zealand society, and it was in response to the poor health status of Māori. And their insistence, and particularly the insistence by Māori nurses, that service delivery actually changed profoundly. And nursing in particular began a process of actually looking at themselves and thinking about how to change nursing education. Cultural safety addresses quality in healthcare through issues about communication and access to health services. And I think it's worth recognising that nurses have been central to this. They're often the first health professional that people meet, and so their attitudes may in fact make a person feel demeaned, may engender feelings of reluctance to either seek healthcare or, importantly, may dissuade people from returning to healthcare services. So the attitude of all healthcare professionals can be expressed, albeit sometimes unknowingly and unwittingly, and if that attitude is one of blame, one of criticism or assumptions, that will set the tone of other interactions for those presenting to that healthcare service. And cultural safety has particular meaning for healthcare. Safety is a word we commonly use in relation to the practice of healthcare professionals, and it must include due regard for physical, mental, social, spiritual, cultural components of the patient, as well as their family, their community, and their environment. So cultural safety assumes that each healthcare relationship between a professional and a consumer is unique, is power-laden, and is culturally two-sided. And from that perspective, whenever two people in healthcare interact, it inevitably involves a convergence of two cultures. So that bicultural component involves unequal power and different statuses, and it often involves two cultures with different colonial histories, ethnicities, and different levels of material advantage. And I think the focus needs to be squarely on health equity, because confronting systemic racism in healthcare is hard work every single day, and it's a process, action and activity. It's not a static, done and dusted concept. And much of the literature refers to the work of cultural safety because it requires healthcare professionals and their organisations to examine themselves and the potential impact of their own culture on clinical interactions and healthcare service delivery. So cultural safety, I think, is about power relationships. It doesn't emphasise sensitivity or awareness. That's, you know, a reflection of knowledge and of diversity and important, but it's about some other things. And in particular, addresses the pain of racism and insists that those who would deny its existence actually must acknowledge it. And it requires healthcare professionals to examine their own cultural realities, their own attitudes and behaviours. So it then requires attitude and behaviour change of healthcare professionals, their teachers, their curriculum, and in service delivery. So if we think then about COVID-19 and its impact, what we're very clear on is that COVID is very good at compounding and making clear all the inequity and all the inadequacies of almost everything we do. So it's unsurprising to see that racism abounds in responses to COVID and how we think about COVID. And if we hold those principles of health inequity and recognising people's varying cultures, addressing racism in view, then how we work with communities and speak with them has to be engaged and authentically caring and well informed. And so that means we can empower them to make best decisions for themselves, and also how others, and look at how others can support them. And when we set that aside and fail to recognise the differential power and status, then I think we can react completely inappropriately. And I think a good example of that was the management of the public housing COVID cluster in Melbourne. And as John Owen said, the delivery method is also the message. So overwhelming people and using the police force to enact a public health measure really fails to recognise the opportunity to engage and involve people in their own health and safety. And this saw a tremendous police presence, as though power differences weren't already apparent, but also failed to recognise that it was a real opportunity to do things differently and to think about the political, the social, the cultural context of people. So I think that that's in stark contrast to the work that June's described, where we've seen extraordinary work on the part of Aboriginal community controlled organisations in working with their communities, working really quickly, having really effective conversations early and shaping the message to suit the context. And I think that's meant that, as June highlighted, COVID-19 in Australian Indigenous communities has been very different to what we've seen internationally, and in particular, including the devastation of some communities in the United States of America, where power over healthcare is not vested in local people, where they're significantly under-resourced and overburdened. So I think the idea of cultural safety really envisages a place or a process that enables a community to debate, to grapple with, and to ultimately resolve any contemporary healthcare issue, but in particular COVID-19.
Thank you. And I think that's so useful, because what it really brings out, the way in which you define cultural safety in terms of power and power relations and also empowerment is really important, because I think often when we talk in terms of culture, that part gets lost. And the histories of the ways in which health and medicine have been racialized, and as I mentioned in the opening, have also been part and parcel of the colonial project, get lost. And it's not transmitted to those who are studying to become doctors and nurses. And part of what we have then is a public perception that health is a domain where everything is equal. And if people suffer, it's due to some kind of racialized, naturalized, deficit within themselves, rather than something about how power is distributed unequally in health and medicine, as well as more generally across the society. And I especially appreciated the fact that you mentioned the Melbourne Towers, because of course, this is something that Dr. Chris Lemmo, who's our third guest, is going to address in his talk. You are an infectious disease expert, Chris, and a general physician at Monash University Health. You recently advised the Victorian Health Department on so-called community engagement in the response to precisely the outbreak of COVID-19 in the 9 Melbourne Tower block estates. The majority of these social housing residents were racial minorities who were put, as we know, under heavy police hard lockdown, which was suddenly imposed without warning on the 4th of July, and which lasted for 2 weeks, while the rest of Melbourne, which is currently under lockdown, was allowed to move around freely. In an interview, you told the Guardian newspaper that you were frustrated by the government's approach, which failed to consult with residents. So could you tell us what you think an anti-racist response to healthcare during the pandemic could look like? Thank you.
Thanks very much. And yes, I'd just also like to begin by acknowledging the traditional owners of the land on which I'm currently sitting in the Kulin Nations, and acknowledge elders past and present, and really appreciate both of you who spoke before me for the wonderful things that you said that really put a really deep and firm context, I think, in the background to all of this. The way that the 9 Towers lockdown occurred really was a very stark expression of the real relationship, I think, between government and people. And again, as has been said many times, it's not a new thing. The relationship between government, the health system, and the population is not a completely benign one. It does have embedded power relations, and discrimination is inherent to the very way that we practice and we think. And we don't really get taught about that when we train, and we don't really talk about it much when we work either. And I think this pandemic has really been a very strict teacher in many ways, and doesn't really let us get away with anything. And it was very clearly the population within those towers was suddenly seen as a threat to everybody else, and given the ethnic background of a lot of the people who lived there, that immediately became a racist kind of picture as well. And the preliminary to all of this, when we've been talking about the pandemic in Australia since December, but more recently since February, March, it's been a very, what I would call a Ramsay Street kind of picture. And it's been a very white middle class suburban as the norm, and everybody else has been a deviant in some way. The only exceptions, I think, were Aboriginal people, because of the way of the, the bitter experience of the past made people realise that they really had to get things moving by themselves and then let government catch up. And the experience of Indigenous people in North America and South America has been a really very horrible, I guess, proof that that was the right thing to do in Australia. And although I think the way that the data is collected when it comes to testing and case definition in Australia does obscure some Aboriginal people, because it's not always collected consistently, I think we certainly have not seen the same devastation that has been seen, for example, in Brazil. However, in Victoria, which is where the most of the Australian epidemic occurs, it's very much disproportionately affecting people from migrant backgrounds, particularly from Africa, but also from South Asia and even South and Eastern Europe as well. So I work in Southeast Melbourne, in probably the most ethnically diverse catchment of any public health in Australia. And what the people that we see on the ward are more similar to the people that we see out in the street, but they're not similar to the people that you see in advertisements and public health messaging. And that's been a really, again, a stark reminder that the default position is to pretend that there's a normal, which is white and suburban middle class, and that everybody else is extra and an afterthought. And when you're talking about a disease that spreads so rapidly, we really don't have time for second thoughts, for leaving people as an afterthought, because by then it's already got into the household, it's already affecting people and their loved ones, and we're playing catch up after that, and it ends up with tragedy. So I think an anti-racist response is really to start with reality, to accept what Australia is as a society, which is a multi-ethnic, multicultural society, which is founded on Aboriginal land, and dominated by an Anglo elite, which isn't really connected with most of the people who actually live here. And to accept that that's the case, and then make efforts to compensate for that structural inequality, and make that the basis of all of our work, in the way that we talk about it, in the way that we record data about it, in the way that we practice, the way that we allocate resources, and the way that we approach people individually when we're providing care, or in a public health sense, when we're actually asking them about contacts and who else might have been exposed, that we don't sort of send people around in uniforms as the first way of talking to them, or get a cold call from the health department from someone who's got no idea of your own cultural context, your own local social environment, the language that you speak best, or what's important to you. All of that is setting us way behind in the conversation, in a conversation where there really isn't much time to waste. And so I think if we can learn anything from this, it would be to accept the reality of what Australia in the 21st century really is, and plan from that rather than from some anachronistic fantasy.
Thank you. I think what you speak to, it's so interesting. Successive Australian government leaders like to talk about Australia as a quote unquote successful multicultural country. And I think it's so interesting because what we see here is that really multiculturalism and diversity are so much window dressing, but when it actually comes to, as you put it, accepting the reality and basing your policy and your action on that multicultural reality, then that somehow seems to be a very, very difficult thing to do. And I think that really speaks to the kind of the poverty of diversity and multicultural discourse rather than anti-racist, anti-colonial discourse, which obviously we can't expect from a colonial government, but obviously we need to, building, I think, on the example that June and Lelon shared with us about how Aboriginal and Torres Strait Islander communities are building the health response, how we can think about what we can do collectively to protect ourselves and protect and care for each other. So thank you to all three of you. I have a final question that I'd like to briefly put to all of you, and we'll take it in the same order as we did before, if that's okay. And the question is, what do you think needs to be in place to support Aboriginal and racial minority and migrant and refugee groups more generally during this pandemic to ensure racial justice in health into the future? So just a small question, but hopefully something you can share a few insights with us on. So first to June.
Hi, thank you, Alicia. Alana, sorry. Yeah, I mean, I think first and foremost, people need to ask and have a conversation and, speak to people. Don't assume that they know best. So, whether it's the healthcare system, whether it's the disability system, education system, COVID, we need to walk alongside communities, the Aboriginal and Torres Strait Islander communities, our new arrivals, our existing cold communities, we need to sit down and really, discuss, what they know, what they understand, what they actually need, but not doing for, doing with. And I think that's where Australia needs to come to now. And let's start a new narrative in this page. Let's open a new page on our books and go, how can we walk alongside you? How can we support you to be the best person you are? Whether that's a person with disability, whether it's our elders, or whether it's our new arrivals. What do you need to support you in your life for, greater health and well-being? And I think it's simple. We don't need to overthink it. We don't need 300 policies. We don't need, a vote to say, about equality or whether who can come in or who can come out or who is a citizen, who is not. It's about, human rights in the end. I mean, our organisation, all our work is from a human rights standpoint and the rights of Indigenous people and the rights of people living with a disability. And people need to know their human rights, the right to access, whatever that is, in a community, whether it's fresh water or access, a quality set of educational standards. So, it's about sitting down, as we would say, sitting down in the dirt and really talking to people, not assuming that they may read English or that not assuming they may know, what COVID is, not assuming that they know to wash their hands correctly. Walking alongside of people and going, how can we help you to be in the best situation that you need to be at this moment? Thank you.
Thank you, Lelon.
So thank you, Alana, and thank you, June. I guess I'd really like to essentially only really repeat what you said. I think one of the things around, particularly around policies, though, I think is that we have to move away from ideas about efficiency and scaling up, because I think we have to recognise the importance of engaging with every segment of the community. And, I agree with you, it's no good boasting of our multiculturalism if we don't actually engage with the multiple cultures. And that means thinking about versions of a solution that suit different people at different times in different contexts. I think we need to strengthen healthcare partnerships between hospitals and community healthcare, between Aboriginal community controlled organisations and hospitals, between disability collectives and disability coordinators, between land councils and municipal councils. I think all of those partnerships go towards ensuring we actually get the detail of our health responses right. And I think they save us from simply applying a template and then criticising people who don't adhere to it. I think we should ensure that pandemic planning recognises the historical, the cultural, the socioeconomic context that any public health measure needs to sit in. And look, I think Aboriginal and Torres Strait Islander people do need to be deeply involved in pandemic planning because they understand that context. And I think that needs to be replicated across our broader Australian communities. And I salute the work done in Australia by community controlled health organisations and recognise that the cultural context that values and applauds obligation and responsibility to community will probably deal with a public health crisis better than a lot of self-serving, business first, highly individualistic, sort of egocentric ethnocentricity that, you know, really fails to recognise the obligations that we all hold and the responsibility that we all have to shoulder.
Thank you. Lastly, Chris.
Thanks, thanks, June and Ron. That's yes, I can only heartily agree with both of those. The only thing that I would add is that there needs to be some actual evidence that that's being done. There need to be actual transparent processes that demonstrate how organisations, how governments are linking with community, how those dialogues actually play out, what decisions are made, who makes those decisions, and who gets held accountable for the decisions they make and the outcomes. And we need to go more beyond lip service and window dressing, tokenism, all of those things to really show how we're doing what needs to be done, which is putting the people who make decisions in touch with the people who are most directly impacted by those decisions, and having the people who are impacted most directly by any decisions have the last word on what gets done. And I think if we do that, it doesn't matter which context, which culture we're talking about, then it can work. And if we don't do that, it will never work. And I guess one of the good and bad things about this pandemic is that because it moves so fast, I do think there really is only one right answer, and that is the right answer to get proper communication and a reciprocal kind of responsibility between the people with power and the people who have to live through it. And until we get that right, we will not get out of this epidemic.
Thank you, all of you, for your considered responses. I think that's given us so much food for thought. I mean, one of the things that strikes me is that so much in this kind of technocracy in which we live, there's this kind of pantomime almost of consultation. So there's steps that people have to go through to say, yes, we've consulted the relevant communities, but as we all know, and those of you in practice know better than any of us, so often that, you know, what communities actually say or what individuals actually say to those in power, those controlling the purse strings, rarely is put into practice, or very often beyond the pages of the annual report and so on. So that holding to account, that transparency that Chris spoke about, I think is so important. And one of the things that's become really clear, I think, in the response to the pandemic, and particularly I'm thinking about during the Melbourne Towers lockdown, was people who were in those towers speaking directly via social media, and that's one tool that we have today that we didn't have in the past, about what was going on, and actually formulating responses, and as I said before, sort of mutual aid, mutual care responses that really actually showed up the poverty of the policed and militarized approach of the government in that situation. So more listening to people on the ground is definitely what needs to happen, unless I think co-optation of them just for the purposes of this happy, shiny veneer of multiculturalism that we spoke about before. I'd like to thank all three of you so much for agreeing to take part in our panel today. It's really been enriching. And I'd like to end also by thanking all of you for tuning in today. And please remember to like this video if you liked it, and to subscribe to our channel, Race in Society, on YouTube. Please tune in for our next episode, which will be on in 2 weeks' time, where we'll talk about the theme of intersectionality and the virus. We're going to feature Carl Briscoe, who is the Chief Executive Officer of the National Aboriginal and Torres Strait Islander Health Worker Association, Professor Karen Farquharson, who's a sociologist and head of School of Social and Political Sciences at the University of Melbourne, and lastly, Dr. Nilmani Fernando, who is a scholar of Black and post-colonial feminisms. So thank you so much and see you next time.